بسم الله الرحمن الرحيم ربي اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Dear colleagues, I am Dr. Ma'an Al-Berri, President of the Saudi Group of Cornea and Refractive Surgeons, which is under the umbrella of the Saudi Ophthalmology Society. On behalf of my colleagues, we are so glad to host our first Saudi Group of Cornea and Refractive Surgery webinar, where we strive and thrive in spreading the scientific knowledge, in highlighting the latest advancements in the anterior segment field, and in exploring new emerging technological innovations. We encourage our attendees to engage with us today in two active pollings and during the question and answer session. And we are so excited to introduce our main guest speaker for today in our first SGCRS webinar, Dr. Kamal Kapoor, who is the co-founder and medical director of Sharp Sight Centers Group of eye hospitals with a chain of 15 eye hospitals across India. Dr. Kamal is one of the preeminent ophthalmic surgeons in the world and has performed over 70,000 cataract surgeries and thousands of LASIK and PHAKIC IOLs surgeries. He is passionate in teaching and has conducted innumerable live surgical demonstrations both in India and abroad, and has presented various papers and instructional courses at the ACRS, SCRS, and AIOS. Dr. Kamal, over to you if you'd like to say a few words before I start my 20-minute presentation.
Thank you, Dr. Bari, and I think it's a wonderful opportunity to meet my friends on this part of the globe. And just before the session started, I was sharing with my fellow colleagues on the platform that it's a beautiful experience for me to cross-learn, share my knowledge, and learn from everybody else. So here's to a beautiful session and a learning session for all. So over to you, Dr. Bari. Thank you,
Dr. Kamal. Okay, can everyone see my? Can you all see my screen?
Yes, we can.
Okay, so these are the board members of the Saudi Group of Cornea, my colleagues in the board. I thank them for all their support and their advice. And let me now move on. Okay, so the lecture today is the posterior chamber PHAKIC IOLs from A to Z. I have no financial interest or conflict of interest in any product that will be mentioned in this presentation. As you all know, myopia is a growing public crisis. In 2010, a third of the world population was affected by myopia, and it is expected by 2050, half of the world population will be affected by myopia. Let me start my stop clock here. Okay. And we all know that myopia increases the risk of some eye diseases like cataract, glaucoma, myopic degeneration, retinal detachment. And there's always, throughout history, been a desire for spectacle independence. So in this talk today, we'll be concentrating on the ventricular-based approach of correcting refractive error. And we're going to, our main talk is basically on PHAKIC IOLs, ICLs, IPCLs, ICRLs. And PHAKIC lenses have been around for more than 50 years now. So this type of surgery really starts with proper patient selection, good counseling, a precise surgical technique, and an excellent post-operative care. So when do we implant PHAKIC lenses? Like other refractive procedures, when the patients are above 18 or 21, a stable refractive error of 1 year, when they're not usually suitable for LASIK or PRK, although in some countries it's the most favorable approach. High refractive error, which obviously cannot be corrected by LVC, and in thin corneas, or if the residual stromal bed is going to be too low. Like all refractive surgery, an accurate wet and dry refraction is definitely mandatory. And one of the beauties of PHAKIC lenses is that it preserves the beautiful creation of the cornea, so there's no flattening, no steepening, no risk of ectasia. And you don't need to abide by the thickness rules or alteration of the Q value, no higher order abrasions. And definitely there are no complications that are seen in LVC like ectasia, haze, decentration, or epithelial ingrowth. So when do we implant them, and why do we implant them? Well, patients basically with PHAKIC lenses enjoy a very high contrast sensitivity. It preserves their accommodation, and now we also have the new multifocals and EDOFs. It's a reversible procedure. It can be implanted after some corneal procedures or lens procedures. There's no fixation to tissue or like iris. It can even be performed in some types of or grades of keratoconus, like grade 1 and grade 2, although this is an off-label approach. It has a very high amount of predictability without inducing high order abrasions in patients with very high amounts of emmetropia. And one of the major advantages really is the retinal magnification. We always see some patients who are slightly amblyopic, they gain a few lines after the procedure. So a good surgeon knows how to perform the procedure, and the better surgeon probably knows when to perform the procedure. And usually we perform the procedure when the emmetropy has stopped progressing for at least a year or a year and a half. Usually in myopia is between -6 and -9. Hyperopia is above 4. Usually the minimum age is 18, although we have a colleague in Saudi Arabia and Taif who's Professor Talal Thimani, who's implanting it even in the pediatric age group in certain situations who have amblyopia and high pathological myopia. There's no intraocular disease. One of the prerequisites that the eye should not have any preocular disease like diabetic retinopathy or uveitis. And one should really study the anterior segment anatomy very well. And I will be elaborating more on this in the coming slides. So the best surgeon is who knows when not to perform a procedure. But before I continue my slides, let me take a poll now. And we're going to take 5 questions just to take an idea of where we stand. Are preoperative anterior chamber angle measurements important before implanting phakic lenses? A, it's not important. Only measure anterior chamber depth, and if it's above 3, you can proceed with the phakic lens. B, yes, measuring the angle is important if it's above 20 degrees. C, yes, it's important if it's above 30 or 35. And D, I don't know. We'll give you like, okay. Okay, so we have, we have like almost an equal C, D. The majority C, 37, but maybe D, 35. And to a less extent, B and C. Okay, let's take the next question. So anyway, people are answering the attendees, and we almost have an equal C, D answer. C is slightly more, 37 answered C and 36 answered D. Okay, let's go to the third question. Is iris configuration, again, I cannot see the full question, but you can guys answer. And here we have most attendees answering again between C and D. We have actually an equal 34 C and 34. Now C is becoming more. Okay, I think we'll end at this point. 45 C, and the rest is distributed between the other. Okay, let's go to the next question. Do you measure the crystalline lens rise? Well, the majority here are answering A. Almost 40% are answering A. Okay, let's take the last question. And what is the most important preoperative variable to measure in phakic IOL surgery? Is it sulcus to sulcus, angle to angle, white to white, or all the above? Wow, 100% all of the above. Okay, so let's end this. Okay, let me continue with my. Okay. So I'm going to skip maybe some of these slides just for the sake of time, and let me concentrate here on the anterior chamber anatomy. And we basically really should look into the anterior chamber depth, the internal anterior chamber depth, the angles, the iris configuration, and the pupil size. We usually measure we always measure actually the internal anterior chamber depth, not the external one. And you can use various machines for that. I usually use the Pentacam AXL wave, and the minimal should be 2.8 or above, not less than 2.8. We also look at the angles, and the angles should be 35 or above, because the angles are expected to reduce after implanting a phakic lens by an average 15 degrees. These are two cases where the angle has reduced by 12.4 degrees, and the other eye reduced by 15.5. Even in the form that is usually shared by Star and other companies, they have a note written in red: do not implant if the angles are less than 35. Because what happens if your angles have become less than 20 postoperatively, this can cause a narrow angle. If it's less than 15, it might induce an acute angle-cortical glaucoma in the future and a high intraocular pressure. Also, implanting phakic lenses in keratoconic eyes, whether grade 1 or grade 2 or whatever, can be deceiving because you can have an exaggerated anterior chamber depth, and the angles can be narrow. So you should always look at the angles, and this is very important. Also, we all know that the sulcus is wider superiorly. So if you're having a high volt, you can always rotate the lens vertically. Observing the iris configurations is very important for any abnormalities, whether it's concave, flat, or convex. And one study showed that you can use an OCT, a Schleien-Flog, or even a UBM interchangeably. They're all just as accurate. And we want to talk about a very important parameter. Maybe I was really unaware of it, except recently, and has been very useful in my practice, is the crystalline lens rise. And that's the distance between the anterior pole of the crystalline lens and the line connecting the angular recesses on the horizontal diameter. And this should be really measured with the anterior segment OCT device. A high CRL above 600 can give you a postoperative low volt. And even if your anterior chamber is less than 3.2, you can have a high chance of pigment dispersion syndrome. Again, one of the important things to look for in examining the anatomy of the anterior segment is to look for any pigment dispersions like Kronkenberg spindles. You should do a gonioscopy to check the angles for hyperpigmentation and retroillumination. Maybe the imposed variable, maybe the most important variable for today is the horizontal white to white, and it should be really measured from the horizontal white to white to the horizontal white to white, and one should really look and check for variance between both eyes. Most people have a white to white that is very close to each other, around 0.2, 0.3, 0.35 maximum difference. So if there's a variance more than that, recheck your measurements by different methods. And ideally, we use more than 2 methods, sometimes even 3 or 4 methods. And you can also double check on the axial length, because some myopes can have higher or wider white to whites. In the past, we used to use the Castrovilliers caliber, but now I've been using, and I think most experts are using, the Vernier digital caliber, because it's more accurate. You get 4 digits, and you can get a much better precise reading, and it is actually the golden standard. Other methods can be like the Orbiscan, Pentacam, IOL Master, although in my personal practice, I found that the IOL Master gives an overreading, although some other studies have shown that it is just as accurate as the Pentacam. I really mainly depend on the Pentacam, the Autorev, and my number one dependence is really on the Vernier digital caliber, and it is actually the golden standard. You can see here in the Pentacam, it can give you this general overview report, gives you the horizontal white to white, the mesopic pupil, and the mesopic pupil is actually another important thing to look into. You can see here down in the blue boxes the optical axial length, and this again can further confirm why the white to white might be slightly different between both eyes. So this is another thing that you can look into. Other parameters that have been really talked about in conferences, many publications, the sulcus to sulcus, angle to angle. And we now know that the sulcus to sulcus is more than the white to white by an average of 0.41 millimeters horizontally. But this can actually vary. Sometimes it can be more than 0.5 and 25% of eyes, or more than even 1 millimeter and 2.3% of eyes. And the correlation between the sulcus to sulcus and the white to white is actually variable and may lead to size mismatching, especially in high myopes. And this has been shown in a number of studies. And that's why we really depend on the white to white. And as you can see, sometimes different machines can give you different readings, but your final decision should really be with the caliber. The mesopic pupil, as I mentioned earlier, is very important, more important than the scotopic pupil, and it can probably alter your decision in picking between lenses, in choosing or customizing the optical diameter of the phakic lens to avoid higher order abrasions. Because if your mesopic pupil is more than 6 millimeters, this can actually induce higher order some photopic symptoms like glare, halos, and starbursts. And it should be really 0.5 millimeters smaller than the optic of the phakic lens. We all know that the cornea magnifies the size of the iris of the pupil, and the optical size of the lens is actually magnified on the corneal surface, just like your optical zone in a LVC. So look into the optical size. It's a very important parameter, especially if you're going to implant. We still don't have this available in Saudi Arabia. The new premium lenses, whether the ones by the Vision ICL or the IPCL, but once they're available soon in the near future, looking into the pupil size is going to be even more important. Specular microscopy is very, very important. On average, we try to avoid patients who have a low endothelial cell count, less than 2,500 if they're at 20 years of age, or less than 2,000 if they're at 40 years of age. Also, thoroughly checking the retina. I usually send them to my retinal colleagues, and they look at the really far periphery. If there's any signs of breaks or holes or whatever, they do a laser barrage, and we usually wait 2 to 3 weeks until these laser scars scar down and protect the retina from any possible, God forbid, retinal detachment. These are the 3 lenses now available. I think they're available almost everywhere in the world. We have them in Saudi Arabia: the iCryl, the ICL, and the IPCL. We all know the IPCL is from porcelain collagen, and this material has really been very safe. I've implanted this. The majority of the lenses I've implanted have been the ICL, and has a very, very safe profile with me. I've seen no opacifications, almost zero cataracts, to be honest. Except if there was a sizing mismatch. It's a very beautiful lens. It's we have the iCryl. I've also had a good experience with the iCryl, and I've started now with the IPCL, and it's a lens that really feels just like the ICL, very soft, very easy to implant, very easy to explant. And all these three lenses are biocompatible, and they all have this central hole. Maybe Dr. Kamal can later on share with us the safety profile. He probably has more experience than all of us today on the iCryl and the IPCL, but they do slightly have different designs and holes in the center and the periphery. The IPCL probably has more holes, more drainage probably of viscoelastic. None of these lenses require PI except maybe for the ICL if you have an hyperopic IPCL. And they have different step sizes. The ICL and the iCryl have 0.5 steps, whether for the sphere or for the toric. The IPCL has smaller step sizes, and you can even custom the optical size and even the overall size for these lenses. They have also holes in the pads, and it is said that these can even give you a leverage if there's an oversizing. Maybe Dr. Kamal can later comment on that, as he has more experience. The incision, definitely ICRL and IPCL can go through a narrow incision than the ICL. And we have now the newer version of lenses. I'm sure Dr. Kamal has implanted many of these premium PHAKIC lenses in his country. Marking is very important. We usually do it at the slit lamp, and we use the 3-step procedure, which is setting the patient up, marking the lens, marking the limbus at 0 and 180 degrees, and then intraoperatively using the Mendes ring, and then rotating the lens into position. And you can also do that digitally. And it was shown that if the lens is off axis, you can actually lose the power of the lens. The ICL, unlike the ICL and the ICRL, has a smart toric, so you'll always implant that lens at 0 and 180 degrees, unlike the ICL and the ICRL, where you need to always rotate according to the plan that is sent by the company. The ICL and the ICRL are usually stored in BSS, whereas the ICL is stored in saline, and this may have a power change. So you need to wait like 1 or 2 days until the true lens power begins to show in the patient's visual acuity. As you can see, the leading haptics differ from one company to another. In the ICRL, the hole is on the top left. In the ICL, it's in the top right. In the IPCL, you should look at the 2 holes like as if the eyes of Mickey Mouse. Here, the 2 holes should always be towards the brows. Also, loading these lenses is quite different. One is loaded from back to front, and the others from front to back. Also, they have different configurations inside the cartilage. The ICRL and IPSL have a concave upward configuration, whereas the ICL has a convex upward configuration. And this is the vault that we usually look into post-operatively. I'll try to skip some of these slides because I think I've taken more than the time I've been given. But vault can be measured by, of course, by slit lamp, but we like to measure the vault by machines because it's more repeatable, more accurate, and you can also look into the angle of the eye. Let me just skip and go to these important slides. If you're going to have a visco implantation of the lens, you should really look for the false low vault and the false high vault. And usually we wait 3 to 4 days until the viscoelastic has really washed out from the eye, until we can really be certain of the true vault. If you're going to do a hydro insertion, then you can have an immediate evaluation of the vault on the immediate postoperative day. And different steps can give you different undersizing or oversizing. As I mentioned earlier, the IPCL, you can oversize and undersize by 0.25 millimeters, unlike the ICL. If the lens is off axis by 10 degrees, you lose almost a third of the power of that toric lens. And if it's more than 30 degrees off, you've lost everything. And maybe this is one of the questions we will be asking Dr. Kamal, the debate of immediate sequential or delayed sequential implantation of these lenses. Do you wait, you do both eyes at the same day, or do you wait 3 to 4 days so that until you assess the vaulting? And I like to delay 3 to 4 days to better measure my vaults and not to double the possibility of an endophthalmitis, TAS, or any other complications. A high IOP in the post-operative period has been really mostly been due to viscoelastic retention, and in the late post-operative due to steroid response. I'll just skip these slides because I really want to finish my presentation. I want to go now to the explantation. We have 3 types of explantation: vertical, horizontal, and oblique. Maybe the oblique is probably the safest approach. I'll skip my video, and I want to go to this case. I just share this one case, and then I'll give the microphone to my dear colleague, Dr. Kamal. So this is a 31-year-old lady who has pathological high myopic astigmatism in her right eye. Her best corrected visual acuity is 20/30. In her left eye, she has a simple pubic astigmatism, and she does correct at 2020. The Pentacam images have shown that she is fit for a phakic intraocular lens in her right eye, and she's fit for a safe laser visual correction in her left eye. She had a good, nice, deep anterior chamber of 3.47 from the endothelium to the lens surface. She had nice wide angles. So we went ahead and we implanted a toric ICL in her right eye, and her angle came down by 15 degrees. So her final angle was 22.4 after 4 to 5 days. And her vision has actually improved to 2020. And this is what I was mentioning earlier, that these lenses magnify the retinal image, and they can give you better visual acuity, uncorrected visual acuity, even better than glasses or contact lenses, because they are much closer to the nodal point. We went ahead and we did laser visual correction in her left eye in 2015. But look here, her volt was 850, but we left this lens alone because her angles were above 15 degrees. Her volt was less than 1000, which is safe, and she had a normal intraocular pressure, so we did not expand that lens, and the patient was very, very happy. And if you look at this very important also parameter, preoperatively, her total spherical abrasion was almost not changed. Postoperatively, her total spherical abrasion and her higher order abrasions are just almost exactly similar in her right eye. And there was no way that laser vision could have corrected and gave her this same visual acuity without altering her spherical abrasion and without altering her high order abrasions and without causing the complications that we mentioned earlier. So in conclusion, yes, myopia is a growing public crisis. There will always be a desire for spectacle independence, and definitely phakic intraocular lenses implantation is an art that I will personally learn from Dr. Kamal. And thank you for your attention. And Dr. Kamal, over to you.
I think it was a very, very exhaustive presentation. I'm just wondering, Dr. Bari, why did you invite me? You've done a beautiful job, and you've touched every salient point which I could have thought of. And I think it actually seems to me that either I have stolen your presentation or you've stolen mine. So it's very, very similar what you've shared. And so what I'll do is I'll probably, there'll be some points which I'll be repeating. And can you see my presentation?
Definitely, yes, we can see it, yeah. Definitely, okay. We wanted to emphasize on the important points, Dr. Kamal. Please emphasize.
Yeah, I'll just go there. I'll retouch some important points which you already have, and some of the points which you may have mentioned, but probably there was not much stress. I'll touch those, and we'll be squeezing around, and we'll also see where are the common mistakes where we end up doing that. And so again, I have no commercial interest in the presentation, any of the products I'll be speaking on. So getting the IPCL or any phakic lens right is dependent on, first of all, right patient selection. And when you do a large number of cases, there are a lot of things where you'll stretch the boundaries, where you feel, okay, this is what the common wisdom says that you should probably not do, but you venture out in those areas. And some areas where you are overconfident and you end up making mistakes. So it's always a great idea to cross-learn from, experts like Dr. Bari there. There are so many things which I was picking up from his presentation. I have no financial disclosure here, so nothing to declare. I just love to share and learn information. So this is my experience with most of the lenses here: iCrills, the Appasamy lens, the Care Group, the Star, and the IPCL. My largest experience is with IPCL, of course, and followed by ICL. I've done iCrills also. So I've touched most of the phakic lenses which are probably available all around. So one basic thing which I did want to bring about before I go into the design is most of the lenses have a hole in the center. Now, till the time there was no hole in the center, a lot of these lenses were causing an anterior subcapsular or an anterior polar cataract. The reason for that was not mostly the touching point of the lens onto the crystalline lens, but the stasis of the aqueous behind the lens. The aqu was not able to circulate and was causing anterior polar cataract. So since the time that the central holes came in, it made the life a lot more easier. But along with the central hole came the issue of glare. A lot of patients would probably start complaining of a glare. Now, this is where different designs of the lens hole, central hole, comes in handy. Now, a few companies believe that if you have a linear vertical tunnel-like central hole, it leads to total internal reflection and causes more glare rather than the slope you have. So this sloping hole gives us an advantage of having a bigger area at the back for more aqueous to come in, a narrower area at the top, and yet since both the sides are angulated, so the incidence of light reflection from the edges is reduced. Now, briefly touching the, we were just before the session started, so we were talking about benefits of LASIK or a corneal refractive procedure versus vis-a-vis phakic lens. I think once you go through this all list, I would not like to spend much time on it. People can take a screenshot. Definitely phakic IOL does win over. The biggest advantage being it's a reversible procedure. Though for a person, normal cataract person or a normal person who's doing a lot of LASIK, the mental block can be that it's an intraocular procedure and it's not just an external procedure. But the plus point is for any cataract surgeon, now I'm repeating again, any cataract surgeon who's doing a decent phakic lens is not a difficult thing. There are few salient points which my friend Dr. Bari mentioned. You just take care of them and you'll be sailing through fast. And the biggest advantage being the amount of infrastructure and dependency on equipment is very, very minimal. All you need to do, learn is a few basic parameters of measurements and working. Now, I'll be just touching the basic. The ICRIL lens and the IPCL lens are very, very similar in the water content and the material made. Though ICL, I understand, would have some issues with the countries where the porcine collagen would be kind of a little bit hesitant to be implanted. But overall, I'm sure ICL itself is a beautiful material. I've done so many of these cases. It's a very soft, pliable material, and so is IPCL, ICRIL, APA, and 4 or 5 other lenses. Now, the road to get it right is, first of all, selecting the right patient. So in the slide where Dr. Bari said who not to choose and who to choose is probably, I'll be just skipping those slides once I reach. Now, case selection and finer nuances. What are the workup and investigations you should require? Special considerations in some typical cases. And the surgery is as important as the way you load the lens. Now, this is one area of phakic lens, which is as important as the surgery itself. How you load the lens would also decide how the lens lands itself inside the eye. Followed by immediate postoperative findings, follow-up periods, complications, and some interesting videos. So patient selection. Broadly, myopia, anything more than axial myopia. So whenever you see a patient with myopia, first of all, we should dilate all these patients. Before we dilate these patients, we do a gonioscopy, we do a specular evaluation, and then we dilate these patients. Now, dilatation will help me to know whether there is some residual cortical sclerosis, which is inducing myopia. A lot of times I've seen my fellow junior eye doctors as skipping mild cataracts, even in younger patients. So the advantage here is that even if you see the cataract, please mention it in the file, inform the patient. Because once this patient goes to another doctor, the doctor will say, oh, you got a cataract. Dr. Bari or Dr. Kamal, Dr. X operated you and you gave a cataract. But if your file already mentioned that there is a minimal developmental cataract or there is a small cortical cataract, you're safe. Now, evidence of nuclear sclerosis, if it is there, avoid doing these cases. Doing an endothelial specular count is very important. Anterior chamber depth for a beginner, I would say, should be a 3 millimeter. 2.8 is what the yardstick says. Yes, I've gotten away with 2.6 also, 2.67, 2.6. But in hypermetropes, it's always a good idea to have the lowest cutoff point to 2.9. I do not go below 2.9 in a hypermetrope patients. But the best part is in hypermetropes, you seldom get such an anterior chamber depth. Lens rise, as Dr. Bari mentioned, I'll be discussing these points in great details. It should be ideally more than 600 microns. Now, what do you do if you have a 750 lens wand? We'll discuss that once we read that particular slide. I do get these patients where I have a lens vault of 680, 700. So how do I bypass these patients is another thing. Now, glaucoma, shallow angle, mid dilated, small pupils, very large pupils is also something to look for. And how much does the pupil dilate is an important point, which I guess my friend forgot to mention. In case your pupil doesn't dilate very well, then also you could be in trouble, especially a beginner. Let's say you have a corneal diameter of 12 millimeters. So you need a 13.25 or a 13.5, but your pupil doesn't dilate beyond 8. Well, hello, you're in trouble. So in case you're an adept surgeon, you've done a lot of surgeries, yes, you'll get away with it. So for a beginner, so even the non-dilated state of pupil is as important that how much does the pupil dilate. It should also be noted. Now, I have had 4 patients where I've had irregular walls in spite of everything. And on doing a UBM, I found that their retro iris cysts were there. So doing a UBM also can be very, very important in these cases. Shallow RDs should be looked for. Doing a detailed retinal evaluation is very, very important. And then last not the least, keratoconus can be very tricky in these patients. Keratoconus patients, even grade 2 keratoconus patients, you need to look at the angle. Now, suppose you have a shallow angle. Now, again, not for the beginners, but I do get away by doing 2 PIs. I do 2 PIs, one at 11 o'clock, one at 1 o'clock, and I do get away with it. So if I'm suspecting a higher vault, now when do I suspect a higher vault? If my pupil size is larger, I of course order a larger optic size. The optic size being larger gives me approximately 100 to 150 higher vault than I've planned. Because the optic size is large, it pushes on the central part of the pupil, creates more angle closure. So pupil size is as important as white to white. So these are 2 things which we always should remember how to do that. Now, this is a brief of, I'm not this now specifically talking about IPCL, nearly 3,000 plus IPCLs done. I've done presbyopic IPCLs also. So the largest, the highest power I've done is 34 diopters, and the largest toric lens I put is 17
Dr.
diopters
Kamal?
of toric lens. Yeah.
You lost your voice.
Can you hear me? Am I audible?
No, you're audible. I can hear you very well.
Yes, we can hear you.
Yeah, please go ahead.
Okay,
Continue,
okay,
Dr.
okay. So all the other lenses would need some rotation, but in IPCL, there is a plus point that the lens is prefabricated according to the patient's requirement. The lens toricity is preloaded. So all you need to do is place the lens at 0-180. Now, again, coming to the size variations, you get mainly 4 sizes in the ICL. You get 0.25 variation size in the IPCL, which means you have approximately 13 sizes available in the IPCL. In ICL, you have 4. In ICL, you need to plan approximately anything between 0.78 to 1.4 or 1.3 millimeter vault and size differentiation. Whereas in IPCL, you can actually plan anything between 1 to 1.5. So that gives you a better understanding of the things. So how to plan the size according to the case, we will see some slides as we move along. So these are the sizes available in both the particular varieties. In an IPCL, you just need to place the lens horizontally, and the toricity of the lens automatically is determined by the lens, and the patients are doing very well. Now, what are the preoperative assessments? Now, this is something interesting. When you're doing an astigmatism more than 2 diopters, in my practice, I also do a vertical white to white measurement, because this vertical white to white measurement actually tells me and helps me to plan my optic size. Now, keratoconus, as I said, since the anterior part of the keratoconus can be a false sense of relief for the surgeon, the anterior chamber can be very, very, deep, and you can see that you feel that you're confident, you can plan a higher vault, but you may land up in trouble because the angle still remains the same. So in keratoconus, since the cornea is steeper at times here, so you get a bigger anterior chamber depth, but the angle is not that big. So you should always measure the angle. Now, in case, as I said, you are planning an angle, as Dr. Bari also mentioned beautifully, that approximately anything between 15 to 25 degrees also, you can lose the angle. Now, again, Dr. Bari, in my study, if the optic size is larger and the pupil is ideally to start with little bit concave, that's when the angle hits a higher level than a normal case. So if I'm planning a larger optic, then I need to factor in anything between 20 to 25 degrees of angle shallowing. So that is a little bit of mix and match, but it might confuse some beginners. So I would restrict by saying that 15 degrees to 20 degrees is a good sign for you to anticipate the shallowing of the angle. And if you feel that for a beginner, you're probably getting less than 30 degrees, it's not a bad idea to do a PI. An ideal PI to do in some situations would be just with a YAG laser 6 to 7 days before the surgery. Measuring the lens rise is very, very important. Gonioscopy in these patients also can be very important. Some patients may have, pigment dispersion syndromes. And as I mentioned, these kind of situations can arise. Now, the highest refractive error I've corrected is -34 with 2 diopter cylinders, 11 diopters. Now, very, very large pupils are big, tricky situations because very large pupils will give you an edge glare. So at times you can do this surgery and also do a single throw 4-pass technique to make the pupil small, or some of these patients can be kept on alpha-GAN for a duration of 3 to 4 months, and then slowly the patient get adapted to it. So this is a trick sometimes I use, though of course in IPCL I can get a measurement up to 8 millimeters of optic size. I have videos where I've done more than 8.25 millimeter optic size. But in case you're able to do that, fine. But in case you're not, you can use alpha-GAN or any drug like that to induce slight amount of meiosis in these patients, and we give it over a period of 3 to 4 months and slowly taper it off, and slowly the patient gets adjusted into that. I've also done a lot of secondary piggyback procedures in patients where we have operated these patients for cataract 15, 20 years ago when they had developmental cataracts as young children, and now they've gone grossly myopic, -17, -20. So this is a good idea to do these piggyback procedures. Now, what are the practical breaking points which we can have? Refraction, always do a cycloplegic refraction in these patients. Irrespective of the fact that they are myopes, it's always a good idea. Sometimes you would land up in trouble by overcorrecting these patients if you've not done cycloplegic refraction. A white to white is always done, and the better word for it in my dictionary is HVID, horizontally visible iris diameter. White to white is very confusing. White to white could be sometimes a scar or a blood vessel or a little bit of a corneal pigmentation. But when you say HVID, the definition itself says horizontally visible iris diameter. Now that actually corresponds to the mid-limbal line. But in cases where using an automated instrument, one good tip is even if you're using a pentacam, like I use Cirrus in all my organization. So even if the Cirrus gives me a reading, I switch to a manual mode. So in the manual mode, I get a big magnified picture of the infrared, and I manually move the scale to the satisfaction. So once you got the measurements right, train 1 or 2 people in your team who do that for you always. So that's where the consistency comes. But suppose there is one person who does 1 white, 2 white in 1 day, and the 3 days somebody else is doing it. That's the time you start getting into trouble, and then you'll blame the product or the surgeon for that. The biggest mistake in IPCL is the white to white sizing. So once you master that, you have got absolutely nothing to be afraid of. Now, if there are minimal opacities behind the implant immediately post-operatively, relax. This is not a cataract. This is a retained viscoelastic. And an ASOCT will tell you this is a retrolental opacity just behind the IPCL. You need to wait for a little while, 3 to 4, 5 days, and it'll just blow out. Now, suppose there's an intraocular pressure rise within few hours. So what we do in my practice is the patient sits in the waiting lounge, has a coffee, sits and relaxes. Just 2 hours before he leaves, he's brought back to the OPD. His intraocular pressure is tested digitally. And if it's high, we do a wound burping from the side port. We'll see some videos. And intraocular pressure at the end of 6 days will always be monitored because of steroid responders. Now, preoperative workup, as I said, cycloplegic refraction. In case these patients have squint, mention it, because some of these patients will come back to you and tell you that you gave them squint because they had the squint, but the squint was hidden behind their thick glasses. And now when the glasses are gone, everybody is noticing these big eyes of these high myopes. And suddenly the mother says to the daughter, "Oh my God, you didn't have a squint. Dr. Kapoor gave you a squint with IPCL surgery." So they come back to you. So in case you do a complete workup, if there is a mild exophoria or esophoria mentioned into the file, tell the patient. If there is an amblyopia, now Dr. Bari, I'm talking about very practical things for beginners. Now, if there is an amblyopia, if the patient is not recovering 6.6 or it's getting 6.9 or 6.12, best corrected, you always mention it. And as my friend Dr. Bari mentioned, these patients will always improve a line or two because of the magnification. But don't promise it. Don't promise it. You know it in your mind that they will improve, but mention it in the file. If the patient is documented not to have seen beyond 6/12, mention that patient was amblyopic and explain it to the patient. And once, if the patient improves more than that, you get more credit. But if the patient is not aware and then he's looking at trying to read the last line on the chart and say, oh, I didn't get good vision, the surgery was not right. So it's a good idea to mention these things in the file. Now, we've already mentioned about the optical zone and, you know, the approximate idea, the cornea seeming, the pupil size seemingly bigger on measurements. Now, I do a dynamic pupillometry on my machine. So we measure the mesopic, scotopic, and normal resting size pupil. So we get these various values, but it's a good idea to just do a simple measurement in a mesopic condition. Now, OB scan actually gives you a good anterior chamber depth, but in my opinion, IOL Master and OB scan do not give a good white to white. I've done a cross comparison study. It's not a good idea at all to rely on IOL Master. And I can be quoted on it because I've done it at various forums. The largest white to white, erroneous white to white you can ever get is with an IOL Master. It can range from 0.32 to 0.56. Now, 0.56 large size is very bad for you to have. So I do not rely on IOL Master at all. Now, vernier caliper in my practice is a confirmatory tool. It is not the tool I start with, because caliper also is dependent on the observer. What we did was I did a study in 30 patients. I gave the caliper to 3 of my trained technicians and told them to write the reading in a register. And then one guy would go, another one would put. So nobody knew what was earlier guy's reading. And all 30 readings were different. Now, what we do in our practice is we use a simple tool like auto-refractive keratometer. I'll be showing you some videos and some images of that. It's very, very fairly accurate. So we use 3 methods. We use a Cirrus on an edit mode, manual edit mode, coupled with an ARK. Normally, these readings do not vary more than 0.15 to 0.2. But if the variation is more than 0.2, then we do the caliper. So if the caliper is nearer to any one of them, that is the reading we take. So over thousands of cases I've done, this works beautifully with us. So relying only on the caliper, at least in my practice, I've seen there is an observer error with the caliper. Like, suppose somebody tells you that this is 11, you'll automatically fix it around 11 and you try and fit it there. But in case you don't know it's 11, you could also be 10.8 or 11.1. Now, 0.3 is a little large size for you to go. Now, coming to the crystalline lens rise, we will see the video. Now, what is this? The crystalline lens rise, as my friend did explain. Now, for me, crystalline lens rise doesn't matter if my ACD is more than 3.2, my angle is 45 and above. But if I have a large pupil, that is the time when crystalline lens rise will matter to me. In a normal pupil size, the CLR does not matter in my practice. I do note it. It is mentioned in the file. So we have the technician colors the reading. If it's more than 600, it's underlined in red. So finally, the sheet sometimes comes to me and then I plan what I'm going to do. So in case the angle is less than 45, we mandatorily do 2 PIs in these patients. But if the pupil size is larger, then we have to think of other means and methods. Now, what is it, even if your anterior chamber depth is more than 2.8 millimeters? Are you safe? Well, yes and no. The reason being, if you're more than 2.8, but your angle anomalies are there, then you could land up in trouble. Your resting pupil size is large, you could be in trouble, even if it's 2.8, because now you'll need a larger pupil size. A larger pupil size will mean a higher walt, and higher walt just in 2.8 is not a good trade-off. If you have an iris configuration which is flat, or you have iris cyst, or you have a higher lens rise. So even if a 2.8 with a lens rise of 600 is slight contraindication, keratoconus, you have posterior synechia. So these situations can be tricky. Now, planning the IOL, as I said, the mid-limbal line, you could use a caliper. These are videos I'm skipping. Now, this is how we use an ARK. ARK is a very, very good tool. So when you're doing this reading, just switch off the lights in your room. So then this suddenly image becomes very clear and you're able to do a very, very reasonable, accurate marking. So you can see the white to white here is 11.44 and the pupil size is 6.6. So this can be repeated 2-3 times and you'll get a consistently similar reading. The trick here is to master to know where the reading actually has to be taken in. Now, as I said, OBSCAN and IOL Master will give a larger readings. Now, sometimes pterygium, pigmented conjunctiva, can cause discrepancy if you're only using an infrared image, because the infrared image will not differentiate between a scar on the cornea or a pigmented thing. So it's a good idea in such cases to resort to your vernier caliper. UBM usually does not give you a good sulcus to sulcus, and there are no nomograms to measure from sulcus to sulcus. If there is more than 0.2 millimeter variance, you need to recheck. If the astigmatism is more than 2 diopters, do a vertical vault measurement also. This will help you to plan your case well. Now this, I think this is just a repeat. So using a UBM to do this is not a reliable method to do white to white. Now this is tricks of sizing the ICL. Now let's see here. Suppose I have an 11.7, I will go for a 13.2, which in this case is 1.5 millimeter larger. But if I have 12.3, I still go for 13.2, which is 0.9 millimeter larger. So that's a huge discrepancy. But when you go to another product which has more sizes available, you can actually fine tune your size realization. Now, when would you plan a larger size and when would you plan a smaller size? You plan a larger size when your anterior chamber depth is higher, when your angles are open, and your pupil size is bigger. Then you can get away with a larger size. But in case your angles are smaller, anterior chamber depth is nearing less than 2.8 or let's say 2.9, and your pupil size is also small, you can get away with a smaller size. Now that is ICL. Now let's come to IPCL, especially the toric IPCL. A lot of times I go one size larger than I want in a toric IPCL, because in toric IPCL, especially a higher astigmatism, I need a good amount of rotational stability. Now, if I have a slightly lesser vault, the lens can rotate. So even a 5 to 10 degree rotation in a 7 diopter toric IPCL can be big trouble for me. So I plan a larger vault, but again, provided my angles are big and my anterior chamber depth is big. So a lot of times I plan a larger vault in my toric patients, and especially high toric patients, where I want more stability. Then in case I'm anticipating a slightly higher vault, I don't even refrain from doing one surgical PI in these patients just to be on a safer side in case I have a little larger vault than I've planned for. This is the kind of workup sheet we have where you have the axial length. Now, all these patients, we do a biometry also beforehand. The reason being, knowing the biometry also gives you a good idea of your real calculations, and God forbid you land up with any trouble. These patients are very highly prone to retina detachments. Now, you do a retina detachment and these patients get a complicated cataract later on. You have all the values with you prior to you did the surgery. So it's a good idea to do an axial length and a biometry and save it into your record for these patients. Now, how do you mark these patients? I use the slit lamp graticule to mark these patients, and it works great. You know, just mark it with a pen, and especially when you're using an IPCL, it's 0 to 180 degrees. So preoperative learnings, as my friend has already said, then ICL is loaded in a reverse manner than the way IPCL is, and one is loaded from the front and one is loaded from the back. Now, before you load the cartridge, even in an ICL, it's a good idea to wash the cartridge from inside. What I do is I make the sponge wet, and I also make the edges of the bottle of the ICL wet with my sponge, because sometimes when you're pulling the ICL with the sponge tends to stick at the neck of the bottle because that's dry sometimes, or the mouth of the bottle. So once you wet that, these are small practical tips learned over hundreds of cases. So once you make the bottle neck and nose wet, the ICL will come straight clean. Otherwise, sometimes while coming out, it sticks to it. And then once it sticks to it, it's a sticky surface. It's very difficult to disengage it. Now, this is how an ICL, most the sizes you see are the diagonal sizes. What probably an average person is thinking it's a horizontal size. No, the size of the lens is the diagonal size. So in a case of an ICL, this flange always is on the left side, and there are so many holes to have an aqueous flow going in. Now, this is a small video. Now I'm just jumping to the video part of it. I'll just go fast to the video. The two holes on the top always go towards the eyebrow. Now, once this is done, you load the lens. Never put a lot of viscoelastic in the cartridge. If you put a lot of viscoelastic in the cartridge, the lens will, it's very light, it tends to float up, and then it will not fold properly. Just put half a drop, and rest should be a BSS. And then before you close the cartridge, make sure that the edges are not sticking out on the edge, pushes in the center, and then as you're closing your cartridge, make sure the lens is not sticking into the flange of the cartridge. Now, once this is through, now the trick, do not overinflate the anterior chamber. If you overinflate the anterior chamber, the iris tends to go back and starts touching the crystalline lens. And once it touches the crystalline lens, now pushing in your ICL or your ICRIL or IPCL is going to be more tricky. So the end point is, the moment your iris diaphragm starts going back, stop. Do not push any more viscoelastic. And now as the lens is coming out, please look, it is landing open right or not. And in case it's not, feel free to rotate your wrist. You have to make it land like an aeroplane straight. So in case it's tilting to one side, you can rotate your wrist on the other side. Now you see these two holes, always in the case of IPCL, are supposed to be facing the superior part or the eyebrow. Now, once this is done, you push more viscoelastic on the top. Now, in the case of IPCL, I engage the central flange first, then followed by the other flange and the third flange. And see, it's over. It's, in a good surgeon's hand, an average surgery takes anything between 56 to 1 minute, 18 seconds. That's one eye over. That's the speed of the surgery once you've mastered it. So you see the lens is inside, it's enclaved both sides. Once you've done it, just rotate it both sides to make sure that all this is, you just rotate, even if it's an ICL or whatever lens, after you implanted it, just rotate it once or twice to make sure the legs have unfolded. Because sometimes after surgery, 2 days, you'll realize there is an asymmetric vault. The vault could be that one of the haptics has not outfolded properly. So I have seen it in 2 cases, and all I needed to do was go in and just rotate it again, and then the lens sets in again. Now, once this is done, I hydrate the wound before I do my irrigation aspiration. The reason being, the moment I finish my irrigation aspiration, the AC sometimes will shallow and the lens will come and snap and the iris will go behind it. So if you hydrate the wound before you start your irrigation aspiration, your AC doesn't flatten when you finish the irrigation aspiration. Another trick I do is I use a free-flowing fluid through a 27 gauge cannula over the holes of the lens. It creates a venturi effect and lets a lot of viscoelastic come from behind. And in the end, always remember, never use the irrigation aspiration port bang on the center of the lens, because sometimes on a higher vacuum, you may pull in the capsule from there and you can have an anterior capsule. One of my friends has reported 4 cases where he was wondering, why is he getting a central cataract? So he said, my ICL is causing cataracts. But I said, what is your vault? He says 700. I said, you could not have a cataract. So I told him to send me a slit lamp photograph. It was a bang in the center, a white spot. In all situations, he probably accidentally sucked in the capsule for some time. So this is how the surgery is done, and it's over. And now, so 2 side ports always, because it gives you flexibility. Make sure they're approximately 5 clock hours. 3 millimeter port to 2.9 for an ICL and 2.8 for an IPCL. Do not overinflate with anterior chamber. Mid-dilated or a small pupil can be tricky in case it's a large pupil. Very, very deep anterior chamber can also be tricky, because a very deep anterior chamber overinflation will cause iris to go back. Loading is to be very important. And once you put in the lens, you make sure to rotate. Now, this is a case of a very large pupil. See, it's causing problems for me. You cannot see the iris. It's so big. And there's a lot of viscoelastic in the eye. So I'm trying to nudge the lens behind the iris. while you're doing this, you have to make sure. So once I couldn't do it, I make some viscoelastic leak from the main wound. And the moment I make the viscoelastic leak, suddenly I start seeing the iris edge and the pupil edge. So in case you're having trouble doing that, just burp the wound slightly and flatten the anterior chamber. You suddenly start seeing the pupil, and you can go ahead and finish this case. So I'll be, sharing these small videos. Now, this is a case where the vault is very high, and you can see the iris is actually closing behind the phakic lens. Now, this patient is come to the OT after 2 hours of surgery, and this was a case operated by one of my junior associates, and he said that the vault is very high. So I just needed to nudge it, and that's what the problem was. One of the haptics was not unfolded. So once you do this, if you rotate it properly, you push viscoelastic, and in these cases, all you need to do is just make sure you put some myotic. Now, what can happen is when you put a pilocarpine on the thing myotic, it can give you a very low vault for first 1 or 2 days. A vault as low as 200. So don't be afraid. In the first post-operative day, if you see a vault of 300 or 200 and you've used a myotic, don't worry. It'll go up by 250 to 300. So first 1 or 2 days, you can, in case you've not used a myotic, a vault more than 150 to 300 due to viscoelastic behind the epicel. So I recommend doing the surgery after 3 days. In my practice, I wait for 3 days, I analyze the vault, and then I do the second surgery. In case I've used a pilocarpine, in very rare situations, I do not use pilocarpine. Then again, I wait for the pupil to become normal before I take the vault. Because with pilocarpine, the vault can be reported very, very normal or very low. So with pilocarpine, if your vault is 550, 600, beware. This is going to be 850, 900 or 1,000 microns. If you use a pilocarpine or a product which causes myopia, this vault will actually go. Now, this is again an interesting case of overinflation. Again, removal of viscoelastic. Now, this is a case where this is 2 cases of keratoconus, both eyes. So in one, I'm doing a peripheral iodectomy with a vitrectomy cutter through the main wound. So the trick is, you need to take out the viscoelastic because you're going to be putting pilocarpine. So first you need to remove the viscoelastic. So once you remove the viscoelastic, you put a myotic, then again put viscoelastic in the area where you're going to do a iridectomy. So I'm putting small amount of viscoelastic just to push the iris behind from that area. And now go with the vitrectomy cutter, 40 to 50 cuts per minute, 250 vacuum, and there you will see we have a beautiful small PI. That's it. So in case you are able to do it with a YAG laser, fine. You could also do the technique of using a side port. Now we'll see how we do that. You can use a side port. The trick is, again, use pilocarpine. This is the other eye of the same patient. Now I'm again instilling small amount of viscoelastic. Now I'm going through the side port. Never do it just under your side port. Always do an angle of 15 to 20 degrees. I tilt the side port 20 degree, and there you have a small PI. So this, you can do that. Now, explantation of this lens is again interesting. So I call it the loop technique or the hook technique. All you need to do is, any lens you can explant, before you explant, put viscoelastic underneath the lens. Open the wound. Now this lens was being explanted because this lens was smaller vault, and there was a wrong sizing done. This was operated in one of my centers. And so I have instilled viscoelastic under the lens. So to make sure that the trauma of touching anything doesn't hit the crystalline lens, then I go underneath it and I dehook one part, the part which is more towards the wound. Once I have do that, I just hook the lens in the hole with a blunt instrument. You'll see all I do. I call it the hook technique. It takes just 10 to 20 seconds to explant this lens. And there you will see, I've got a lot of videos on the YouTube. Now, once I've got the hole exposed, I'll go there again. You just hook it and bring it out. Either you can use a needle holder or you can hook it out with a blunt instrument and the lens comes out. Now, in case there is an immediate IOP rise, how do you manage it? Now, this patient, after 2 hours of surgery, some viscoelastic was remaining. You see the cornea is totally steaming. You see, it's a steamy cornea. So how do we deal with this? You just put a little bit of local anesthetic, ask the patient to look up, and since you made 2 side ports, go to the inferior side port, 26 gauge needle bevel down towards you, just push the side port, make the wound burp, and immediately you'll see the cornea starts clearing up. You must ensure that before the patient goes home, because this IOP needs to be brought down, because otherwise these patients will start vomiting, and due to the vomiting, the vault will keep going up, the iris will come out of your wound, and then you're again in big trouble. So as a practice, as a routine practice, 1.5 to 2 hours of surgery, all patients are actually evaluated on the slit lamp. Now, vault, again, what is a vault? Again, I'm sure we all know about it. A half corneal thickness vault is important. Now, these are some patients. This is -27, -29. This is -34. Now, these are very interesting cases. This is a patient of corneal perforation with, you see, astigmatism of 11 diopters. Now, you see, we did this patient. Now, this patient did not have any cataract, only had a corneal perforation. So we put in a customized 11 diopters phakic lens in this patient. This is one of my old videos. This patient was 6/12 unaided from 11 diopters astigmatism. Another patient of central corneal scar, this was 5 diopters patient. Now, this is an interesting case, which I operated many years ago. It was 18 years ago I operated this patient, and this is an interesting case. There is a residual -17.5 with 2 diopters cylinder in this patient. Complete posterior synechiae, fibrosed lens, and -17, I could not do much for this patient. I planned to do a piggyback IOL, but then I realized I don't have much space. The angle was not so good. So I do a sphincterotomy, get a customized phakic lens manufactured for this patient, implant a -17 lens, and this patient was good to go. So this was done for this patient. Now, this is the patient post-op. Now, this is another very interesting case. It's a small non-dilating case, operated many years ago, total complete fibrosis of IOL, complete posterior synechiae, -13 diopters, thin cornea. Now, how do you help such a patient? We get a 4.5 millimeter customized phakic lens manufactured for this patient. Now, operated 12 years ago. Now you can see this is a totally fibrosed phakic lens. I'm showing you some very interesting cases to actually tell you that the scope of work with phakic lens is far more. So I try and dilate with, dilating the pupil. I'm going fast forwarding the thing. Now I do a small amount of sphincterotomy. I break all the adhesions and -13 diopters. Now you must see this. This is a 4.5 millimeter 12 millimeter by 4.5 millimeter optic size. This is again a customized lens made for this patient at -13. And the best part was this patient did phenomenally well. He was refused from a lot of places and he came back to me. He was not from Delhi. He was from somewhere other place, and he came and we operated this case. So these are few. This is again, in case you end up doing a large PI, you can tattoo it. This is again one of my cases because this patient had a shallow angle. So I asked one of my glaucoma surgeons to do a PI. He did a huge PI. You can see the retroillumination. So this patient was very happy with the vision, but he said at night, I see 2 headlights. I see street lights as 2. And he went to my other doctors and they couldn't figure out what's happening. So all I did was I just lifted the lid slightly and I saw the retroillumination. So I just tattooed that area in front of the cornea and the patient said, I'm absolutely fine. So these are some very interesting cases. This is again a case of keratoconus operated by one of my colleagues. You can see the anterior chamber depth in this case, Dr. Bari, was 3.4. But look at the angle. Post-surgery, we had to explant this lens. So when you're operating a keratoconus case, so I guess, thank you. Now any other questions? So I tried to skip a lot of slides which you'd already mentioned. I tried to touch some other points.
No, excellent. I mean, perfect presentation. Actually, Kamal in Arabic means perfection. You gave us a perfect lecture, and we already have so many questions here. Okay. Let me take some questions here. We have some on on the Zoom, and I have some here on my mobile. So let's take the first question here. So again, you mentioned this, and I also mentioned it, but maybe you can answer it again. How do you measure the crystalline lens rise? Do you take it from the angle to angle, of sulcus to sulcus?
Angle to angle.
Angle to angle, and then anything above? And you always use your UBM, or you can use any other device?
No, UBM, I don't use
OTT,
the UBM
sorry.
because, it's very difficult to measure it on the image quality of the UBM. So I use my Cirrus machine. It gives me a very clear lens rise. You can actually manually edit that also. You can bypass the automated measure, and you can use Cirrus is a beautiful machine. I have no commercial interest, but I have 11 of them in all my centers. So it's a very good time you have.
Okay. And how do you confirm your white to white but manually? Do you use a digital caliper, or you use the Castro caliper?
Digital caliper.
Digital caliper, more accurate. Okay. Does the IPCL haptic pad holes provide a blending ability if the IOL is oversized? And if so, how much?
Yes, I think that's a beautiful question. Somebody actually who's been using is asking this question. Because if you actually go back to the diagram I showed, the IPCL has got some cuts in the edges of the haptics, which make it very soft and pliable. So it doesn't dig into the zonules. And in case it's pressed, it backfolds slightly. So it's very, very forgiving to a larger vault also. Another good point about the IPCL is that even if you keep an IPCL on a flat table, it will maintain a vault of 400 microns, which is a new concept which most of the people will now start using. The inherent design itself, even if it sits on a flat table, it maintains a vault. So in case, even if it's loose, it will rotate, but it will not cause a cataract, because it will not come and touch in the center. So I hope that answers the question.
Very good. Okay. Also, another question. Do you do immediate bilateral sequential or delayed bilateral sequential PHAKIC IOLs? Do you always wait?
I do a delete. What about you? What about you, Dr. Bari?
No, I always delayed. I always, just as you said, 3 to 4 days.
3 to 4 days, absolutely.
Yeah. I have never tried the hydro insertion. Have you ever tried the hydro insertion?
Yes, I do hydro insertion because sometimes it can be tricky. 1 or twice I've had the lens, which actually flips over very fast. So I still remember 2 months ago, I operated a daughter of a bureaucrat, and she was supposed to fly to Canada after 1 week. And the lens it was a hydro insertion. It just went like this, and it was sitting on the endothelium. Now, my tricky situation was one of my instrument was in the left hand, hydrating the wound. And the moment I go in to rotate it again, the wound opens and the fluid starts coming out and the chamber flattens. So it causes more trauma to the endothelium. And rightly so. Next day, for next 4 days, I could not sleep at night because this young girl had a central corneal edema. And the father wanted to ask me that should he cancel the ticket for the kid to go to Canada, because he thought that something was wrong, because the first eye hydro insertion went absolutely fine and the patient was seeing. In the second eye, the patient after 4 days also was not seeing clear. So that's why I would not recommend hydro insertion for everybody. But yes, it has its own plus points. But if it doesn't land right, it can cause problems.
Definitely. So for beginners, maybe visco insertion is better. Maybe if you become an expert. Okay. Do you check the white to white between both eyes for variation, like ISO white to white, ISO axial length, to make sure that that your readings are accurate?
Absolutely. They are compared, and whenever there are more variations, it's done a double check. In the sense, I have 2 teams of technicians in each hospital who are trained to do this. So in case there is an issue, one technician just moves aside without sharing any of the data with the next one. The next one comes in and reconfirms.
Okay, we have a very limited experience. Most of the PHAKIC IOL implanters in Saudi Arabia have been mainly implanting the Visian ICL. And we've just recently starting implanting IPCLs. How safe is it? Does it opacify? Can it cause a cataract? There's so many, fear from using the alternative lens.
I think both lenses are great. ICL is a great lens. I use a lot of ICLs also. Most of my patients who come and ask for an ICL, I do an ICL for them. But if the patient has no choice, then my choice of lens is an IPCL because of the size variability, the customization, the toricity, the toricity is incomparable. I have no commercial interest here. I've done 10 diopters, 8 diopters of toricity, because the lens, all you need to do is put it at 0-180. There are no manipulations. So the accuracy is superb. So if I have a high toric lens, my first choice is to go in for an IPC.
So it's very safe, because we have a question, another a similar question.
No pacifications of the lenses, nothing. No inflammations, no reactions. I've done more than 3,000 and more than 9 years now. Long follow-ups. I've started with a V1 model. And in case, just for the audience, I'm one of the co-designers of the new model of the lens. I have a lot of interaction with the company people. We decide what to do.
Okay.
So there's a lot of stuff, information flowing up and down from users, not just me. A lot of high volume users are getting in touch with the company. We should do this, we should do that. So it's a constantly evolving design.
It's also preserved. I mean, the preservative of the ICL and the ICRL is different from that, from the IPCL.
Absolutely, yes.
So
the power is absolutely stable. The patient would be, bang on required vision within first 4 hours.
Oh.
The patient is watching television the same day, evening. Now that's the beauty of it.
Okay. We also
you can have a minus 24 diopters patient watching television unaided in the evening, and next day, they come back with 4 or 5 of their friends and say, okay, doctor, she's my friend. She also needs this power. She also needs this surgery. So that's your marketing tool, that the same day they are able to see clearly.
Okay, Dr. Abdullah, I see he also has a question. You've answered his first question. What is the best method to measure the white to white? You said you have the Sirius machine. I have the Pentacam. You've noticed that the Ion Master 700 gives an overestimation.
Absolutely.
And
yes.
you would not recommend on the AutoRiv. You also mentioned that the AutoRiv. I actually use more than 4 methods. I use the AutoRiv. I use the Topolizer, which uses a Placido. I use the Pentacam. Absolutely. And I use the 4-digit, the digital caliber. So 4 means.
And I think it's a good idea to be as sure as possible, because this is one measurement which can actually break or make your case.
Precisely. And he also has another question, Dr. Abdullah Asiri. What is the maximum volt you would accept?
Again, it would depend. I think that's a very good question. It would depend on 3 things: the angle I have, the anterior chamber depth I have, and the pupil size I have. I have patients with me who are I have in my another presentation photographs of their ASOCT, 1325 volt. Patients doing fantastic, 4 years. And this fellow is a tennis player in Australia. He's a Sikh gentleman who's plays professional tennis in Australia. And I was scared, when I told him that you need to stay back, I might need to change your lens. So we observed him over 4, 5 days, 7 days, 10 days. So then when he went to Sydney, I told him you be on a follow-up. And then he was on follow-up. So every once a year, he comes to India on Diwali days. So I tell him, please visit me. And he's doing fantastic. It's been 4 years. He's doing great.
Also, a third question with Dr. Asiri. Which IOL formula would you consider if you, with IPCL?
You don't need to change your IOL formula. I think that's a very, very good question. You do not need to change the IOL formula, because the IPCL or the ICL is so thin. In the thinnest parts, it's in the center, approximately, it's anything between 70 to 100 microns. It doesn't make a difference. It doesn't make a difference. You can actually go ahead with whatever formula you are using. You could use a Barrett, or you could use a Holiday 2. You don't need to make any changes in that. Okay. You don't need to make any changes.
Does a dilated pupil change the AC depth measurement?
Yes. Absolutely. I think this is again a wonderful question. Suppose a few of my patients where I have a very, very low volt and I'm planning to explant the lens, I keep these patients dilated till I get the new lens.
Okay, we also
I hope the people could get what I'm trying to say. If you dilate the lens, the volt goes up by anything between 150 to 250 microns. And if you construct the pupil, the volt can go down to 150 to 200 microns. So in case I have a low volt and I feel I might get a cataract and I want to explant this lens, and it's going to take some time before the next lens comes in. So I keep these patients dilated to make sure that the volt is there and I don't have any touch happening inside. So dilating increases the volt and constriction of the pupil decreases the volt.
Okay. Okay, we have also a question here from Dr. Saad Al-Harbi. If you have a low volt, when would you consider explanting it, and what age? Less than 100 microns? We have people like, Silverstein, who would never explant the lens unless they're a cataract, even if it's 0 for him. And then
Okay.
what's your input on this?
Okay, if it is the V1 version or the earlier version of the ICL, I would explant at 250, 200 and below, because there was no hole in the center. And these were the patients which I saw who had cataract. In case there is a central hole and it's not a toric lens and it's not rotating, I have, I think 3 or 4 patients with me, 150, 180 microns, ICL, they're doing well, and I've just kept them under observation. I don't do anything. But if it's a toric lens, I would want to explant because this lens would rotate and cause problems.
Yeah, we'll be just going round and round.
Yeah.
Okay.
If it's a spherical lens, you can actually wait and watch.
Wait a moment, unless you see a change, then you will explant.
Absolutely, yes.
So
I think you got it right.
Can you implant? Rahul has asked the question. Can you implant with the 2.68 millimeter AC depth?
I would not recommend for any beginner because this needs a lot of training, because it's not the lens which may cause the cataract, but it's your implantation and putting it enclavation. The surgeon itself may cause the cataract. So you need to actually be very well adept with knowing that where to hold it. So I think this comment has to be deleted, that at 2.67 you should do it. Let's keep the 2.8 as a
Reference.
hallmark, because somebody will go ahead and try it, and for a beginner it can be a big problem.
Okay, what is the youngest age that you've implanted the phakic lens?
16 years.
Okay.
The reason being, this patient
have
was
the Guinness in Saudi Arabia.
Anisometropic. Patient was anisometropic. The otherwise was totally emmetropic. This patient was approximately -14 here.
Dr. Our professor Tarar Tumali in Taif, in the central west part of Saudi Arabia, he's implanting it in pediatric age groups, and he has published. He has a publication. I think it's
The
available.
only concern is that my only concern is you cannot predict the vault in young children. The eye size may change.
Okay. How? By the way, we did not emphasize on UBM to rule out iris cysts. Do you do UBM?
I mentioned that.
You mentioned that?
that.
Okay, okay, yeah. So maybe I just
I mentioned that. In fact, I mentioned that iris cyst. In 4 of my patients, I was getting a bad vault in one eye, and everything was fine. The data was fine, and then I did a UBM to find, and I had 4 patients where there was retrolens iris cyst, and we had to explant the lens.
So do you think it's a must? Some people don't have UBMs in their center.
The incidence of iris cyst is very less. You know, thousands of lens surgeries done. I just have 4 patients.
Okay, okay.
And not everybody has an access to UBM, so I don't think it's a big mandatory thing.
Okay, and we have a question here by Jinan Al-Hamad. How do you how to be sure that the ICL is in the correct place, not inverted?
That's very easy. If it's inverted, you will never get a good vault. You will always have a flat vault, number 1. Number 2, the holes on the sides are always the indicators. So it's always should be concave downwards. The marking holes of the leading holes and the tracking left and right holes need to be right. And of course, you will know on a slit lamp, in case you got the ICL upside down, your iris will have actually a convex configuration, and you will have the ICL touching the crystalline lens on your ASOCT. So you can't miss that. It's very, very easy to catch.
Now it's my turn. I want to ask questions now.
Okay.
I have maybe 1 or 2 questions only. I've been implanting. I'm not an expert like you, mashallah. You have much more experience and you've implanted much bigger numbers. But I've started implanting phakic lenses since 2006. But after the COVID-19, after the lockdown was over in 2020, I implanted a number of cases, and I had 4 consecutive cases that developed pigment dispersion syndrome, despite having deep chambers, wide angles, and I'm very obsessed about deep chambers and wide angles. But at that time, I wasn't looking at the CLR, the crystalline lens rise. Do you think that could have been the problem?
I think more than the CLR, it could be the iris configuration which is causing this. Because you see, the CLR at the most is going to cause a low vault or an anterior lenticular contact syndrome. Here it is the iris configuration. And your presentation said it beautifully. You know, iris configuration is one of the things which is often missed. So
Yeah.
that's what I said, you know, you need to look at the iris configuration. So if the, even in your initial cases, sometimes you miss these things. And that's where your iris configuration, if it's a little bit flattened or it's more concave, it can cause this pigment dispersion.
And there's no way of fixing it? Doing a second
No way of
PI?
fixing it. Yes,
Yes,
there
you
is
have to
no way
explant.
of fixing it.
You
Yes, you
have
will
to
have to
explant them.
explant
You have to
because
explant
these
them.
patients will probably get a chronic iritis. Some of I have one patient who had ciliary tenderness, constant ciliary tenderness, and ciliary redness, and you know these my glaucoma associates were saying, sir, we'll get into a pigment blockade, so you'll probably need to explant. Then first I thought I'll go and wash the anterior chamber with a bimanual cannula and get away with it, and nothing worked. So we had to explant the lens.
Okay, the final question is something that we still haven't experienced here in Saudi Arabia, and you are the expert. You've done many of these cases, and we would like to just to hear from you, from your experience about. It's a very simple question. What is your experience with the new multifocal IOLs, the EDOF phakic IOLs, and have you implanted these in pseudophakic eyes?
Yes, a big yes. If you're talking about the multifocal and the bifocal piggyback lenses of phakic lenses, yes, I have. I've also done primary and secondary. More so in secondary because of my previous patients where I've done monofocal lenses and they now want multifocality. I have yet to use the EDOF phakic lens, but the diffractive lenses I've used a lot.
But the EDOF can just, I mean, how much add power? I mean, if someone's 45.
It's a very good question. Very good question. Yeah. Okay. Now, I always, if the patient is, first of all, my cutoff is 47 years. The patient has to be above 47 years. So I always, when I take a patient of 47 years, I do one eye first, the non-dominant eye. And I target +2 to +2.25. And I let the patient be. Most of these patients are very happy. They don't need the second eye. Now, in case I have got only 3 patients where I've done the second eye after 4 to 5 years. Most of the patients have been happy with one and they are continuing. Secondary lenses, I've done a lot of them. With both eyes, they had the pseudophacos monofocal lens, and I've gone ahead and done a piggyback of a phakic lens, which is diffractive. EDOF or the enhanced monofocals, I have not done those phakic lenses.
Excellent, Dr. Kamal. It was a really wonderful lecture. Before you go, don't leave us. I want to share my screen again. Let's take the poll again. Let's take the poll again. Let's see what effect your presentation, more than my presentation, had on the audience. Again, let's take the poll. Are preoperative anterior chamber angle measurements important before implanting phakic IOLs? A, it's not important. Just measure the AC depth. If it's more than 3, go ahead and implant. B, yes, the AC depth should be more, the angles should be more than 20 degrees. C, yes, important. It should be above 30, 35 degrees. D, I don't know.
There are a lot of people who joined late, so they probably missed the first poll.
Okay, yeah, no, wow.
Wonderful.
Yeah, wow, now it's in the 90s. Okay, good. So that's the power.
That's interesting.
That's the power that you've had by staying up late, Dr. Kamal. Okay, let's take the second question. Let me close this. Okay. Bismillah. Okay. Is pupil size important in phakic IOL surgery? A, not important. Yes. Scotopic pupil size should be larger than the IOL optic. C, yes, the mesopic pupil size should be larger than the IOL optic. D, I don't know. Wow.
You can already see the shift now.
Yeah. Some still hesitant, huh? But still, the majority got the right answer.
Yeah, absolutely.
Okay, let's see. Let's take the third question. Is iris configuration an important matter to screen for preoperatively in phakic IOL surgery? A, it's not important. B, it's important. Avoid convex iris. C, it's important. Avoid concave iris. D, I don't know. Again.
People are still slightly confused with this one.
Yeah. Now give them the answer, please, Dr. Kamal.
No, I'll tell you. You see, they could be both right, because in my talk, I did said even a bad concave iris can lead to pigment loss.
Yeah. Okay.
So they're both technically right. Technically, they're right.
Very good. Okay. So let's go to number 4. Do you measure the crystalline lens rise preoperatively in phakic IOLs? Or let's say, is it important to measure the crystalline lens rise? I don't know. Yes, it's important. Yes, I do measure it. It's not important.
Great.
Let's make the question, will you measure it in the future? From now on, after this presentation.
I think so.
I think so.
Yeah.
Yeah, I think so.
And you see, the thing is, crystalline lens rise, people need the equipment to do that. That also depends on the availability of the stuff they have.
An OCT?
An OCT doesn't actually, I've tried it with an OCT, it doesn't give a very good evaluation. A good Scheimpflug topographer gives you a very good, exact information. You get the same value again and again and again.
That's very good. And the last question, what is the most important preoperative variable to measure in phakic IOL surgery? Sulcus to sulcus, angle to angle, horizontal white to white, or all of the above?
Yeah, I see a beautiful shift now. Yeah, that's good.
Yeah, it's definitely C.
Yeah, I can see the shift.
C is the correct answer.
Yeah, C is the correct answer, because we did say that sulcus and sulcus is possible, but doesn't give you reliable information.
Dr. Kamal, we look forward to seeing you in Saudi Arabia in person.
Thank you.
You were great. Once a wonderful lecture, and we hope you can invite us and we can have chicken curry in India.
Thank you. I sure. I think I look forward to that.
I really enjoyed the talks from both of you. I think this is one of the changing lectures and talks I ever attended. So I'm really thankful for both of your talks. There is one
Thank
two
you for the
questions,
invitation.
if possible. Dr. Kamal, if you answer one, there is a lot of questions as Dr. Ma'an mentioned, but one question is about your experience about with the hyperop patients. If you can summarize it.
Absolutely, I'll summarize it for you. Hyperop patients tend to do very well, but of late, my surgery of choice in hyperopic patient has been a clear lens extraction, without doubt, with a simple enhanced monofocal lens, because most of these patients do not give you the anterior chamber depth which you require, because the cutoff, the hyperopic eye is far more unforgiving. Angles are not good. The anterior chamber depth is not good. Very rarely you get an anterior chamber depth of 2.9 in an hyperopic patient. So I operated one of my staff 6 months ago, and I told the staff that I'll operate you in case you get a cataract. I'll be doing a clear lens extraction. So one eye he did get a cataract because the vault was definitely less than planned. So we do the clear lens extraction, and after that day, I've actually reduced doing phakic lenses in hyperopes. I just go for a clear lens extraction in these patients, and I correct one eye. I use enhanced monofocal lens. I do a second myopia on my IOL master, correction in the non-dominant eye with an enhanced monofocal, and an emmetropic in this. And these patients, both eyes open, are practically super happy.
And the other one is post grafting, post PKP ICL. Have your experience in that?
No, we've not done that. We're not doing that. No.
You don't do ICLs or yeah. So
thanks. Let's take a few more questions, Dr. Kamal, if you don't mind. I just went through the question and answers. Since you're up late, let's just finish all these 5. What is your experience recommendation for the near ad? You've mentioned that. Polycarpine absolutely avoided in the operation. You absolutely avoid.
Yeah, I avoid for the simple reason, if I'm planning the second eye within next 2 3 days, and the patient, I get a lot of patients from overseas. I get a lot of patients from Europe, East Europe, Africa, a lot of places. So I cannot plan my surgery well. So I always avoid using a myotic because it doesn't let me plan my vault for the second eye.
Okay.
It takes at least 2 days for the vault to start settling down.
And Nasser al-Shihri, how do you avoid the haptic tear during loading? You said you have to like weten the cartilage when
Yeah.
you pull the haptic with the forceps. You can also, I use the twist technique. I don't pull.
Yes.
I just
You
twist,
just
twist,
pull
twist.
the cartridge. Don't pull the lens. Pull the cartridge.
Do you hold the haptics behind you? Okay. And I know a comment, I've seen pigment dispersion in a patient who went for an aggressive exercise post ICL. Another one had it because of using moxifloxacin intracamerally. Have you had pigment dispersion because of aerobics,
No, no,
excessive
no,
exercises?
no, nothing. Never,
Moxifloxacin?
no.
Do you use
Never.
intracameral moxifloxacin?
We started, but then I left because we in an organization, you see, whatever I start, it has to follow by everybody. So I usually don't use anything in the eye. No intracranial xalocaine, nothing. We use nothing.
I've been really using the moxifloxacin. I've been using it routinely, really, with the
As you understand, somehow I feel, it's still a little off the label, and the making the concoction, you are actually adding one more factor which can be out of control.
But also endophthalmitis. So it's always
in fact,
a double
there was
sword.
a paper presentation. There is in Shankara Netralaya, my friend has presented a case of 12,000 cases with moxifloxacin, and suddenly their TAS went up.
Okay. Do you CXL patients before keratoconus patients before implanting phakic lenses?
Yes, 8 months, at least 8 months before, and stabilization on this thing, your topographer, flattening. I noticed no shift in flattening not more than half diopter of astigmatism, thinning of the cornea should not be going on, and the refraction should be stable. So look for these things, but I've seen usually it takes 7 to 8 months before I take the patient in for a phakic lens after keratoconus.
Excellent, marvelous. Dr. Kamal, we really apologize for having you stay up late. What time is it now?
I enjoyed it. It's 1 o'clock.
Wow. Okay, so we don't want to keep you even later than that. Thank you very much, and thank you to
Welcome.
Dr. Arfad and to the chapter and everyone.
Thank you for the invitation.
So
I look forward to more interesting sessions. Thank you.
We all enjoyed your talks. Thank you so much, Dr. Kamal and Dr. Man. Thank you so much.
Thank you, Dr. Bari. Good night.
Have a nice
Good night.
Nice sleep.